When you hear the word tuberculosis or TB, you probably think of a lung infection. It's a disease often associated with a persistent cough, something we've known about for centuries. But what many people don't realize is that this tenacious bacterium can travel. It can leave the lungs and set up shop in other parts of the body. One of its rarer, more deceptive forms is called tuberculous peritonitis. This is an infection of the peritoneum, a thin, delicate membrane that lines the inside of your abdomen and covers most of your abdominal organs. It's like a smooth, protective wallpaper for your belly, and when it gets infected with TB, it becomes inflamed and can cause serious problems that are easy to misdiagnose. At the heart of tuberculous peritonitis is a very specific microscopic villain, Mycobacterium tuberculosis. This is the same bacterium responsible for the classic lung infection we all know as TB. It's a remarkably resilient organism, capable of surviving inside the human body for years in a dormant or latent state. For most healthy individuals, their immune system can effectively wall off the bacteria, preventing it from causing active disease. However, the trouble begins when the body's defenses are weakened for any reason. This gives the dormant bacteria an opportunity to reactivate, multiply, and spread beyond the lungs through the bloodstream or lymphatic system. The most significant risk factor for developing any form of active TB, including tuberculous peritonitis, is a compromised immune system. People living with HIV are particularly vulnerable because the virus directly attacks the immune cells that are essential for controlling the TB bacteria. In fact, the risk of developing active TB is estimated to be between 16 and 27 times greater for people with HIV than for those without. The symptoms of tuberculous peritonitis are notoriously vague and often develop slowly over several weeks or even months, which is a key reason it's so frequently missed. The most common sign is abdominal swelling or bloating that gets progressively worse. This is caused by the gradual accumulation of acidic fluid in the belly. You might notice your clothes feeling tighter around the waist or a sense of fullness, even when you haven't eaten much. Alongside the abdominal swelling, a persistent, low-grade fever is another classic hallmark of the disease. This isn't usually a high, spiking fever that sends you straight to bed. Instead, it's a temperature that hovers just above normal, often accompanied by night sweats and a general feeling of being unwell or malaise. You might feel unusually tired all the time, a profound fatigue that doesn't improve with rest. Many patients also experience a loss of appetite, which combined with the underlying infection often leads to unintentional weight loss. Diagnosing tuberculous peritonitis is like solving a complex puzzle. There isn't one single test that gives a quick, definitive answer. The process begins with the most fundamental tool in medicine: listening to the patient. Your doctor will take a detailed clinical history, asking about the timeline of your symptoms. When did the bloating start? Have you had a fever? Have you lost weight without trying? After taking your history, the doctor will perform a thorough physical examination. They will carefully press on your abdomen to check for tenderness, signs of fluid buildup, and sometimes a characteristic doughy feeling, which can be a subtle sign of the inflamed peritoneum. They will listen to your lungs to check for any evidence of pulmonary TB, as about 15 to 20% of patients with tuberculous peritonitis may also have an active lung infection. The next steps involve a series of laboratory tests on your blood. A complete blood count, CBC, might show signs of anemia, which is common in chronic diseases, or an elevated white blood cell count indicating an infection. Your doctor will also likely order an erythrocyte sedimentation rate, ESR, or a C-reactive protein, CRP test. These are non-specific markers of inflammation in the body. Once the initial history, physical exam, and blood tests suggest that something is wrong inside the abdomen, doctors need to look inside. This is where medical imaging plays a vital role. The first imaging test often performed is an abdominal ultrasound. It's a quick, non-invasive, and safe procedure that uses sound waves to create pictures of your organs. An ultrasound is excellent at confirming the presence of acidic fluid in the abdomen. For a more detailed view, the gold standard imaging test is a computed tomography or CT scan of the abdomen. A CT scan provides cross-sectional images, kind of like looking at individual slices of your body, offering a much clearer picture of what's happening. On a CT scan, doctors can see the extent of the acidic fluid and look for specific signs highly suggestive of tuberculous peritonitis. These include a smooth, uniformly thickened peritoneum that lights up brightly after the injection of contrast dye. While imaging provides a picture, the most crucial diagnostic information often comes from analyzing the acidic fluid itself. To get a sample, doctors perform a procedure called paracentesis. This involves numbing a small area of the abdomen and inserting a thin needle to draw out some of the fluid. The procedure is generally safe and provides a wealth of information. The first thing doctors look at is the fluid's appearance. In tuberculous peritonitis, the fluid is typically straw-colored or yellowish and is an exudate, meaning it has a high protein content and a high white blood cell count. Preventing tuberculous peritonitis is fundamentally about controlling tuberculosis at its source. The most effective strategy on a global scale is to promptly identify and treat people with active pulmonary TB. When individuals with contagious lung TB are successfully treated, they can no longer spread the bacteria to others, breaking the chain of transmission. This reduces the number of people who become infected in the first place. On an individual level, the Bacille-Calmette-Guerin or BCG vaccine is an important tool, particularly for children living in countries with high rates of TB. The BCG vaccine is most effective at preventing severe disseminated forms of TB in infants and young children, such as TB meningitis and miliary TB. While its effectiveness in preventing adult pulmonary TB is more variable, by protecting against the widespread dissemination of bacteria in childhood, it can indirectly reduce the risk of extrapulmonary forms like tuberculous peritonitis from developing later in life. Good public health measures also play a significant role. Mycobacterium tuberculosis thrives in crowded, poorly ventilated indoor spaces. Improving ventilation in homes, schools, workplaces, and public transportation can help disperse airborne droplets and reduce the risk of transmission. Additionally, tackling the social determinants of health is crucial. Malnutrition is known to weaken the immune system and increase susceptibility to TB. Ensuring access to adequate nutrition, especially for vulnerable populations, helps build a stronger physiological defense against the infection. The good news is that tuberculous peritonitis is a curable disease. The treatment is based on the same principles as treating pulmonary TB, using a combination of powerful antibiotic drugs over a prolonged period. The standard treatment regimen lasts for at least 6 months and is divided into 2 phases. The first phase, known as the intensive phase, typically lasts for 2 months. During this time, patients take a combination of 4 drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. This initial 4-drug blitz is designed to rapidly kill the majority of the bacteria and prevent the development of drug resistance. After the 2-month intensive phase, the treatment moves into the continuation phase, which lasts for another 4 months. During this period, the regimen is simplified and patients typically continue taking just 2 drugs, usually isoniazid and rifampicin. It is absolutely essential that patients take their medication exactly as prescribed for the entire 6-month duration. Stopping treatment early, even if you start to feel much better, can allow the more resilient bacteria to survive and multiply, potentially leading to a relapse of the disease. In addition to the anti-TB medications, supportive care is a critical part of the recovery process. Many patients with tuberculous peritonitis are malnourished and weakened by the chronic illness, so nutritional support is very important. A diet rich in protein and calories can help the body regain strength and support the immune system in fighting the infection. While most cases of tuberculous peritonitis can be managed with medication alone, surgery is sometimes required in specific situations. However, for the vast majority of patients, the combination of the right drugs and supportive care is all that is needed to achieve a full cure. Navigating the complexities of a rare disease like tuberculous peritonitis can be daunting, but understanding the essential points can empower you to be a better advocate for your own health. It's crucial to remember that this is not a lung disease, but an infection of the abdominal lining caused by the same TB bacterium. It is uncommon and often mimics other conditions, making it a true medical detective story. The people most at risk are those with weakened immune systems, particularly from HIV, or those with underlying conditions like chronic liver or kidney disease. The symptoms to watch for are a classic but subtle gradual abdominal swelling, or ascites, a persistent low-grade fever with night sweats, and unexplained weight loss. Because these signs are so nonspecific, it is the combination of them, especially in a person with risk factors, that should raise a red flag. If you experience these symptoms, a thorough medical evaluation is essential. Diagnosis is a multi-step process involving a careful history, blood tests, and advanced imaging like a CT scan to visualize the abdomen. Finally, and most importantly, remember that tuberculous peritonitis is treatable and curable. The standard treatment involves a 6-month course of specific anti-TB antibiotics. Sticking to the full course of medication is the single most important factor for a successful outcome. With the right diagnosis, the right treatment, and good supportive care, patients can overcome this challenging infection and return to a healthy life. Awareness is the first step, and timely medical care is the path to recovery. Don't ignore the subtle whispers from your body, they could be telling you something important.